Dr. Weinberg, thank you for joining us once again on MD Newsline podcast. For those who don't know, can you please introduce yourself to our audience?
I'm Frank Weinberg. I'm a thoracic oncologist at University of Illinois Cancer Center here in Chicago. I run the thoracic oncology program, and I also do a lot of translational research as well.
Yeah, speaking of translational research, we've got some exciting news coming out of your camp. Can you please walk us through just the genesis of this Sybil study and how this AI tool emerged from concept to implementation in clinical studies?
Oh gosh, yes. So it is exciting work. This basically was spearheaded by my colleague Mary Pasquinelli, who runs the lung cancer screening program here at the University of Illinois Cancer Center. So she, about 2 years ago, we were at the World Lung Conference in, I think we were in Singapore actually, and there was a really interesting presentation about Sybil, which is basically an AI tool used in lung cancer screening to kind of predict your 6-year risk of developing lung cancer off of a low dose CT scan. At that conference, Mary actually went up to Dr. Sequist, who kind of had spearheaded uh, implementing Sybil into the clinic. Now, Sybil was developed by Regina Bardsley and her lab at MIT. And so together, Dr. Sequist and Dr. Bardsley worked together to kind of implement Sybil into the General Hospital population. But it was apparent that, that cohort and Sybil, they basically validated Sybil on the National Lung Cancer Screening Trial cohort and the NLST cohort, which led to the current guidelines of lung cancer screening as we know it here in the United States. That was a very homogenous population, primarily a white population. And so they started thinking about, could this be validated in other populations? And so this consortium, the Sybil consortium, kind of came to be as a way to kind of recruit other populations into this study to kind of validate Sybil within that. And so Sybil was also validated in a Taiwan cohort, which is also homogenous, but it was in an Asian population, right, which is different. And now this consortium has 4 different sites, basically. It has us, UIC, which we predominantly see African American patients, underserved, underrepresented patients. It also includes another large health system down in Tennessee, Baptist Memorial, which is also a very diverse patient population. It also serves Wellstar, which is another patient population or a large patient center down in the Southeast, I believe. And so together, these 4 groups kind of, our question is, can we validate this in a larger cohort of patients? And so that's kind of how we integrated it here at University of Illinois, basically to see if this Sybil tool works in our population.
Yeah, I'm all about this really fascinating and emerging field of AI being used in health care services, especially when it comes to things like screening. We talked a little bit about the homogeneity of previous implementations. What other unique clinical need or gap in lung cancer prediction and screening was Sybil specifically designed to address?
Well, so when it was implement or started, it was kind of thought, they had high hopes that this was going to be able to be implemented throughout populations as a way to kind of improve detection of lung cancer early on, right? We know that the guidelines that we have for lung cancer screening, while they capture a lot of folks, they don't capture all folks. And our own data here, Mary Pasquinelli did a lot of this work, showed that, the current guidelines for lung cancer screening, which is basically based on smoking history as well as age, don't do service to the patients that we see. A lot of our patients don't smoke enough to get into lung cancer screening. I know that sounds crazy. I think the thought of Sybil, once we can validate it in a large population, heterogeneous population, is that we'll be able to maybe utilize it along with other factors to really bring precision-based lung cancer screening to folks and be able to screen potentially outside of what the guidelines are. for folks that we know are at risk for lung cancer.
Hmm. And speaking of Mary Pasquinelli, her leadership was highlighted in the press release and presenting the data. Can you describe your role as senior author and how this collaboration unfolded?
So Mary is she is extremely enthusiastic. She is a go-getter. She saw this presentation and knew that Sybil was something that we needed to integrate into our population, primarily because of what I just said, because we knew there was a disparity in our population when it came to screening on national guidelines, right? And so, her initial thought was, can we use this in our own institution? And I kind of was along for the ride in another sense, but I help her kind of understand maybe some of the biology that we could integrate. I have a lab, and so we're really interested in sort of taking Sybil to another level. Obviously validating it in populations and is very important, but then starting to try and use Sybil along with other factors, primarily biological factors, which I know we're going to talk about in a little bit, to kind of help, again, guide something I like to call precision guided lung cancer screening, right? We have precision based oncology. We should also think about precision medicine in the lung cancer screening space as well. Sybil helps us get there.
Interesting. Can you share a little bit about the design of the study presented at ISLAC 2025 meeting?
Sure. So it's a retrospective study, basically. So all we did was we took our lung cancer screening population that we have here, and we looked back at baseline low dose CT scans. And this was about 3,000 patients that we looked at. And we basically ran Sybil on this low dose CT at baseline and got basically a Sybil score. And from that, we were able to tell how well Sybil accurately predicted lung cancer development in our cohort, which it does very well.
Interesting. So, given that the study population was predominantly Black and socioeconomically diverse, what did you learn about model performance across different demographic and clinical subgroups?
I think that's where the next step is headed, right? We're going to try and figure out what are the factors. We don't know what Sybil really utilizes on the low dose CT to kind of make its prediction, right? And so I think there it can be helpful. We can look at something called the attenuation map of the image to kind of see what exactly is it that Sybil is sort of focusing on, right? And from there, we can integrate other factors, other clinical factors, other biological factors, and understand whether or not, these things are represented potentially in a CT scan.
Mm. That's really interesting. And for people who aren't necessarily familiar with artificial intelligence and how it's used to analyze, healthcare data, can you kind of explain a little bit about what you mean by not necessarily knowing what it is that Sybil is honing in on in those CT scans for the person who has no idea how this is being applied in the medical field?
I think the thing that helped me understand it the best was when Dr. Sequist presented her data, she showed basically a low dose CT that Sybil was run on. And you could look at the map of what Sybil was focusing on, and you could see, oh, this was an area of the lung that was concerning. Now, there wasn't anything there at that point. And fast forward 2 or 3 years later, she had the follow-up CT scan that showed that's exactly where the cancer developed.
Mm.
We don't know yet all the factors that are potentially going into that prediction, right? That's what we're trying to sort of understand. And there will be a lot of prospective as well as retrospective analysis on trying to understand exactly what Sybil is using to make these determinations. It's a bit of a black box right now, and we can all kind of agree on that. But this is why we have a consortium that we're able to look at these things and kind of really get down into the details and try to understand what is it that Sybil's using to make these predictions.
Yeah, and for those who don't understand, the artificial intelligence was trained on data historically, and then it began to pick up on patterns with a from looking and analyzing in a way that only a artificial intelligence can do, a great deal of data, picking up on patterns and then using that information was able to then look at CT scans and with a impressively high amount of accuracy was able to predict, even though there was nothing that doctors could see, um, lung cancer development in patients, which is really fascinating. Thanks for that caveat to lay the foundation, because I know some people just have no frame of reference
It's
for this.
hard, and I don't have a background in this
Mm,
myself, so this is important because I think we're going to see more and more AI
mm,
integration into the medical field. And so we want to understand exactly how it's being used. But what I'll say is that, you know, I think this was either Dr. Bardsley or Dr. Sequist or maybe Dr. Pasquinelli, they made a comment that the data is only so good as the data that you put into the model, right? And so doing all of these sort of retrospective analysis up front, where we get a large heterogeneous population, we're validating Sybil in all of these cohorts, will only make the model stronger down the road.
interesting. Were there any unexpected findings in the way Sybil stratified risk or interacted with clinical variables?
Um, Again, we don't have that data yet, but I think, that's the next step. Some of the stuff that we are doing here at UIC, we've geocoded. Basically, we have the addresses of all of our patients who are in the lung cancer screening program. We can see where they live. And now we've overlapped sort of population metrics of social determinants of health. These can be pollution exposure. These can be food deserts. We can kind of overlap those metrics on top of things and see, do some of these factors overlap with a high Sybil score or a low Sybil score, and I think there we're going to be able to get at, are there other exposures?
Mm.
Are there other clinical characteristics that are also associated with high or low Sybil scores that we should maybe be thinking about as we go on to screen patients?
Interesting. When it comes to disease, one thing that we always talk about, and I may have discussed this with you previously before this study, is there's always this conversation around inflammation, um, and uh, oxidative stress. And I'm wondering if there are measurements for oxidative stress in any way, shape, or form, or kind of like a presence, because even when it comes to things like acid reflux, whether it's silent reflux, things that are degrading the mucous membranes, and then there's studies that talk about how cytokines could kind of like, there's this crossing of the membrane and then kind of triggering an autoimmune response in another part of the body that's beginning in one part. You have things like MS, right, where women are more likely to have it, and even what is it, NAD plus receptor encephalitis, where again, women are more likely to get it. And we're thinking, does it start in one area and then kind of move along? And I'm wondering if any of those kind of factors with these themes that keep coming up when it comes to disease states might be going into, things like Sybil, where people might be more likely to get them. Even with oxidative stress, you have people who are neurodivergent are more likely to respond, how it impacts like depression and how stress impacts oxidative stress and things like that. And that makes me think of socioeconomic factors. That makes me think of pollution. That makes me think of epigenetics and things like that. So are any of those things kind of going into this multitude of, this immense amount of data that's going into Sybil? I wonder
I
what
I
might.
love that you brought up oxidative stress because in my previous life as a PhD student and then as a postdoc, I worked on the mitochondria basically,
The
and
powerhouse of the
the
cell, I hear.
powerhouse of the cell line and how it
Yeah.
integrates into cancer
Mm-hmm,
in
mm-hmm.
specific. So oxidative stress is something that's near and dear to my heart. So what we're going to be doing is, or not that we're going to be doing, we are doing it. We're collecting blood samples on these patients enrolled in the lung cancer screening program here. These blood samples will be used to analyze for metabolites, to analyze for cytokines, to analyze for immune cell populations. And then we plan to integrate that data along with Sybil scores. I think together, that's back to my point about integrating biology with, Sybil scores.
Mm-hmm.
I think hopefully from that work, we'll be able to develop more personalized lung cancer screening
Mm-hmm.
and potentially have better factors to kind of predict who's going to go on to develop lung cancer than what we have right now. This has all, I mean, not to go off, but,
Please.
you know, we think about screening. We screen a lot of people who don't need to be screened, right? They meet the criteria, but we know that across that cohort I talked about, the NLST cohort, only about 1% of patients in that who qualified for lung cancer screening, that's based on age and based on smoking history, actually went on to develop lung cancer, right? We're catching obviously a lot of lung cancer early, and that's great, but we're screening a lot of folks that probably don't need to be screened. And we also know our own data, about 3% of our patients in the same population develop lung cancer. So there's disparity there, right? So while, we're picking up patients, we're not picking up everybody. And then even when we are, there are disparities within those populations of who's going to develop lung cancer. And so, you can see we need better tools to kind of personalize lung cancer screening. It's not a one shop fit all sort of thing, which is kind of how it's set up right now.
Do these tests cover things like mutations and things like that? I know that with, I'm just coming from reference of like neurodivergence. There's like an MTHFR mutation that, increases likelihood of different disorders and things like that. I'm wondering, as we're kind of gathering data and like feeding it into the machine, are things like that, even with breast cancer, for instance, you have people with the same type of HER2 positive, HER2 negative breast cancer reacting completely different to treatments and stuff. Are we kind of setting ourselves up for the future to be like, you know,
Yeah, I think that's where we're going. Again, we're not there yet, but a study that we just are going to present actually here at North American Lung Conference in December is going to be basically looking at patients who were diagnosed with lung cancer through the lung cancer screening program and their genomics versus those that weren't. I can say that, it doesn't look like there's much difference in terms of the genomics between the patients, but think about the genomics of these patients who develop lung cancer within the lung cancer screening population and how you could potentially start to understand how the genomic alterations might correspond to Sybil scores, right? So we plan to integrate Sybil scores into these folks and see, are certain mutations more associated with higher Sybil scores or lower Sybil scores, right?
really interesting. So, what barriers exist for embedding this technology into things like electronic health records and radiology workflows?
Yeah. So Mary Pasquale could really talk about this because, like I said, she is the workhorse. She's the one that got this up and running here. And she went through a lot of no's before she got yes, yes, yes. And I think the one thing we learned in talking to our other consortium institutions are it's not a one shop fit all sort of thing. The way you implement this is very dependent on the system, and what the system has and what the system doesn't have. And so it's been really interesting to see how other systems kind of integrate this technology. There was a great presentation sort of on day one of the World Cancer Conference that we just presented all this data at. It was a workshop basically. And Dr. Findelman, who was a radiologist who was at Mass General, who was very involved in implementing Sybil into the radiology workspace there, kind of talked about how, the implementation kind of works of this technology. It's actually easy. When you see it laid out, it's not that hard, but, these systems now have a lot of stops. And so you have to kind of navigate how to get around those stops. And I think it is going to be very much dependent on the system. I think the thing that Mary and others who have implemented it can provide is sort of a troubleshooting help, right? Because we've been through it. We've gone through all of these different iterations and gotten it to work. So she and others could be really helpful in other institutions that are looking to truly get this up and running at their place as sort of help to get this, tool integrated into their system, but it's going to be different for everywhere.
And when you say stops, you're talking about kind of the red tape around electronic health records and each institution's individual policies and practices. Makes sense. How might this tool alter the timing or frequency of CT scans and other standard lung screening protocols?
So that's always been so we have a Thursday morning meeting with the consortium, 40, 50 people are on it every single Thursday. And now, we're really interested in retrospective validation. We're also interested in prospective studies now, right? And we have some money from organizations that are going to fund some of those prospective opportunities. The intervention is what comes up a lot. How are you actually going to use, the Sybil tool to make a change in treatment, right? I have so many patients that would come in and I could give, say, hey, this is going to change, you have a high risk score. We're going to screen you now 3 months instead of 6 months. They're still going to ask, but I want you to get the cancer before I don't want to ever get cancer. Right. And so how is that screening actually going to impact that? Or how is using Sybil actually going to impact that? I think that really gets at what we're trying to do here, which is integrate Sybil with sort of biomarkers that might predict, hey, this person, you're at a way higher risk that you're going to develop lung cancer. Is there a preventative strategy in here that a medical preventative strategy, right, that we could use based on your biomarkers that could potentially, ameliorate the risk of you even developing lung cancer? I think that's that's what all of us hope, that down the road, sure, it's great. We're going to be diagnosing lung cancer very early, but we know there's still recurrences even in stage 1, right? And so how do we actually get to a point where people aren't developing lung cancer, right? And I think that, that's some of the work that we're doing here hopefully will add to that.
Interesting. So lung cancer disproportionately impacts underserved populations. How does Sybil help reduce health disparities?
So, I mean, we know Sybil works in our population. Our population here at UIC is 70% African American in the lung cancer screening space. So, I think the fact that Sybil is validated and works well in our population can be one way that we could potentially ameliorate that, that disparity. I think, the things that Mary and myself are working on now are the prospective studies. And a lot of these studies are designed to screen outside of the current guidelines, right? We know that we're not picking up, especially in our patients, we're missing a lot of patients, right? That the current guidelines don't work well for our patients, right? And so a lot of what we're trying to do is kind of figure out, can we use Sybil? Can we use other things to kind of screen outside of the guidelines to pick up more people who are at high risk for going on to develop lung cancer?
Yeah. When it comes to using artificial intelligence, we talk a lot about, training and validation data, especially with diverse populations. Can you discuss how the consortium ensured that data from diverse racial and socioeconomic backgrounds were included during training and validation?
So I think that was one of the issues that they ran into when they started, that they validated this initially, or trained it initially on NLST data, which is very homogeneous data, primarily, I think 95, 96% white cohort, right? And so that was what really gave rise, I think, to this consortium, was the fact that we need to include much larger number of patients, but also a much more heterogeneous population. And so, it was nice that, there was a Taiwan group that validated a Taiwanese population, but again, that was a homogeneous population as well. So trying to, when they were kind of creating this consortium, ensure that there was a lot of representation, that when we validate Sybil in this population, it's going to, we're going to be able to tell, does it perform better in this group? Does it perform better in this group? And so that's really, I think, one of the reasons why there was interest for having UIC involved, was because we are an academic institution that does have a very diverse population. And so, could we use Sybil in that population? And how does it do? And now we know, it performs pretty well in our population.
What lessons did you learn about deploying AI responsibly in a diverse population compared to a more homogenous trial cohorts?
So I think we're still learning, right? So the study, like I told you, is a retrospective study. So we haven't actually, it's not patient forward yet, right? That's to come. And so I think some of the work that we're going to be doing is understanding from a community standpoint and also from a patient perspective their views on this AI tool. What do our patients actually think of it? And we're going to be doing a large survey actually prospectively to kind of understand, if we, you know, use this tool, what do you understand? Is there, what kind of education uh, needs to be thought about when we're thinking about integrating AI, and then also how are patients actually interpreting what we're saying about the tool in itself. So we're going to get some of that data. That's up and coming
Mhm.
work that we plan to do here.
And you mentioned NLST already a little bit, but I'm wondering how Sybil compares with existing validated risk models like PLCO, M2012, and NLST.
So it's a little like, so when we talk about comparing to risk models, we have to understand that Sybil is a little different than PLCO and those models, right? Sybil is basically you're looking at a low dose CT scan, right, in a patient that doesn't have lung cancer yet, right, to see what their overall risk is in 6 years, right? The PLCO is set up a little bit differently. It's and these other models are set up differently. Some look at pulmonary nodules, and some look at your high risk, for example, based on your smoking and whatnot. So these models, we have to be very careful when we're using the model to kind of interpret these risk models, if that makes sense. Not all of these models can be compared, together, right? PLCO was primarily, I think, lung nodules. Basically, you had to have a lung nodule. Sybil, you don't have to have a lung nodule. You'll get a score no matter what, even if there's not a nodule there. And so, that makes it a little hard to interpret exactly what these models mean. I think, the goal is to utilize Sybil and create a model that's going to be not necessarily a one size fit all sort of model, but one that can be kind of tailored potentially for each patient that we're seeing. And Sybil can maybe be the backbone of this. That's how I'm thinking about it here at UIC.
And this is all really fancy, but how scalable is this approach for smaller centers without significant computational infrastructure?
Right. That gets back to sort of the implementation of all of this. And, we're not in the consortium, we're actually the smallest center. The other centers are larger, right? And we've had these conversations on the calls and whatnot about how do these smaller institutions or these small places really integrate this sort of technology. And again, I think it's going to, there's not a one size fits all. And I think, the more and more people like Mary Pasquinelli and others integrate this at institutions, will understand better how this can be scaled to other um, places.
What has been the biggest scientific and operational challenge in coordinating across institutions like UIC, Mass General, MIT, and others? We talked a little bit about, the potential for stops in electronic health records, but what else did you come across?
Yeah, I mean, I think whenever you have a consortium, whether it be in this setting with an AI tool, or whether it be in a biorepository sort of setting with collection of samples, or just sharing data in general between sites, it can be a large, that's a big ask for all entities, right? How do you protect PHI? How do you, ensure that the data is all collected the same way so that it's can all be used and analyzed together. The great thing about the consortium is that there were lots of talks about how we were going to collect the data and what we should be collecting, and making sure that there's sort of a standardized approach to how we're collecting data. And of course, going through the process of data use agreements and all of that, that those are all things that have to be in place for a consortium like this to operate, which, we have. So, there are a lot of there are a lot of things that have to be considered when you're thinking about putting together a large consortium like this.
Where does the consortium see Sybil's role over the next 3 to 5 years in clinical trials versus real world screening?
The hope is, I think, that, with some of the funding that we have, we're going to be doing these prospective studies to kind of show that, number one, it's validated in populations, right? In a heterogeneous population. And number two, it can be used sort of hopefully to screen outside of the screening guidelines. Hopefully to, down the road, be integrated into practice to help, again, improve detection of lung cancer. My hope is that in 3 to 5 years, we might have some interesting biomarkers that we've discovered that, kind of correspond with Sybil scores that we might be able to start thinking about as sort of a preventative strategy, a medical preventative strategy.
Data privacy is an ongoing concern. How is patient data being secured and safeguarded in this AI-driven approach?
Again, Mary Pasquinelli kind of took the role on this, and our institution, we ensure the privacy and that all health information is protected. She worked closely with our centers of translational science to ensure that all of our data there was no way that an outside source could ever access this data. Again, the workshop that they actually the Sybil workshop at World Lung, which you can actually watch online, I believe, kind of talked about the fact that, how you can safeguard, patient data while you're running this. You don't have to run this tool through the internet. You can download the tool and kind of run it, off so that it's not associated with any network or anything, to kind of ensure that you get data and your data's, hidden and private.
What other research questions has this study opened up for you as a translational oncologist?
I mean, the biggest one is, if we have a way to kind of better stratify our patients who, are in lung cancer screening, then how do we now understand the biology of that stratification? This tool, again, gets back to the beginning when we were talking about what does it use, right? We don't really know what it uses, right? We know that it works because it's been validated in our population, but now, we want to be able to understand the other factors, whether it's clinical, whether it's demographics, whether it's biomarkers that can be integrated in here that can truly, I think, help us develop precision-based lung cancer screening guidelines, right? And down the road, preventative strategies.
And are there any plans to expand Sybil beyond predicting lung cancer, for example, applications in other thoracic malignancies or cancers detectable via imaging?
So the MIT colleagues, Dr. Bardsley's group, is very interested in that question, and she's actually worked, I believe, they have something similar in that she developed in the breast cancer space. But yes, I think AI technology, this sort of technology, we want to expand it. We don't, potentially one of the things that we're thinking about is validating Sybil in lung nodule population, right? These aren't necessarily patients or individuals that are going to come in through lung cancer screening programs. These lung cancer screening programs are high risk populations of patients, not necessarily patients with lung nodules. So one of the first thoughts was, does Sybil work in, patients who are being identified have a pulmonary nodule identified in the emergency room, for example, who aren't part of lung cancer screening. So that's, another part of the consortium, and we're going to be doing prospective studies in that space as well. So I think, yes, there are going to be other applications of Sybil to, other spots in thoracic oncology and oncology in general, and probably outside of oncology.
Wow. Well, this has been an amazing conversation. Thank you so much for spending time with us here on MD Newsline podcast.
Thank you.